This video simulates catastrophic cellular failure. When a single lysosomal enzyme stops functioning, its specific target substrate cannot be broken down. That undegraded material begins exponentially accumulating inside the core of the cell, forcing it to swell. This toxic accumulation is the unifying cellular mechanism of all lysosomal storage diseases, or LSDs. Depending on the missing enzyme, the stored material might be sphingolipids, glycosaminoglycans, or glycogen, but the end result is the same: tissue packing, organ damage, and systemic decline. Because these dozens of diseases look molecularly identical, manifesting simply as packed, failing cells, clinicians must rely on strict phenotypic binary anchors, such as the exact size of a spleen or the presence of specific debris in the eye to differentiate them. Extracting these precise clinical markers dictates the patient's survival. Classifying the exact subtype of LSD determines whether a patient receives a standard intravenous enzyme drip or requires a high-risk surgical intervention to save their brain. The clinical matrix for these diseases is dense, so navigation requires a strict heuristic. The baseline genetic rule is that almost all lysosomal storage diseases follow an autosomal recessive inheritance pattern. This diagram demonstrates the required diagnostic shortcut. To evaluate a patient, you must immediately isolate the exceptions. Here, the massive autosomal recessive block splits, as 3 distinct nodes break away to form an X-linked cluster. These exceptions are Fabry disease, driven by a GLA mutation, Hunter disease, or MPS II, driven by an IDS mutation, and Danon disease, driven by LAMP2. Committing these 3 exact exceptions to memory is the mandatory first step. Any clinical presentation that suggests an X-linked pattern immediately narrows the field of over 50 diseases down to these 3 possibilities. This animated logic tree maps the diagnostic pathway for sphingolipidoses, starting from a primary ocular anchor. The central root node represents the macular cherry red spot, a visual indicator of ganglioside buildup in the retina. From this ocular finding, the first critical clinical fork occurs. The physician must physically palpate the patient's abdomen to confirm the presence or absence of hepatosplenomegaly, a severely enlarged liver and spleen. Following the absent pathway leads directly to Tay-Sachs disease. These patients lack the hexosaminidase A enzyme, exhibit an exaggerated startle reaction, and belong primarily to the Ashkenazi Jewish population. They do not develop organomegaly. Moving down the present pathway brings us to Sandhoff disease. Here, a combined deficiency of Hex A and Hex B affects multiple tissues, resulting in an enlarged liver and spleen alongside distinct bony dysplasias. Also on this present branch is Niemann-Pick type A. These infants have an acid sphingomyelinase defect that causes massive hepatosplenomegaly and triggers a rapid, severe decline of the central nervous system. If the ophthalmologist spots the cherry red macula, the diagnosis is already narrowed. From there, a simple physical evaluation of the patient's spleen dictates the final biochemical classification. Panning the logic tree to a different set of symptoms, we find the branch for patients presenting with both hepatosplenomegaly and progressive central nervous system disease. This presentation requires evaluating for Gaucher disease, the most common LSD overall. Gaucher is driven by glucocerebroside accumulating in macrophages. This infiltration packs the bone marrow, causing ischemia, necrosis, and excruciatingly painful bone crises. We must divide Gaucher into its specific phenotypes. Gaucher type 1 involves only visceral organs and bones. Gaucher type 3, however, adds severe progressive neurologic decline. Under this central nervous system branch, we place Niemann-Pick type C right next to Gaucher type 3. Both diseases present with the exact same combination of massive organs and severe neurological progression. To separate them, we look at the eyes again. Gaucher type 3 limits eye movement horizontally, resulting in a lateral supranuclear gaze palsy. Niemann-Pick type C restricts movement up and down, presenting as a vertical gaze palsy. Noticing the isolated geometry of a patient's failing eye movements perfectly separates a sphingolipid synthesis defect from a cholesterol transport failure. This annotated X-ray introduces the mucopolysaccharidosis, or MPS group. These diseases involve the accumulation of glycosaminoglycans, which deform the skeletal structure. This specific array of deformations is called dysostosis multiplex, characterized here by the J-shaped sella turcica in the skull and widened oar-shaped ribs. Returning to the diagram, the MPS diagnostic tree hinges on a definitive ocular finding. We branch from the MPS suspected node into corneal clouding present and corneal clouding absent. The present pathway leads to MPS 1, or Hurler syndrome. This is an autosomal recessive disease marked by severe cognitive decline, coarse facial features, and thick, clouded corneas. The absent pathway points to MPS 2, or Hunter syndrome. Patients with Hunter share the coarse features and skeletal issues, but their corneas remain completely clear. Because Hunter is one of our 3 foundational exceptions, it strictly follows an X-linked inheritance pattern. A critical outlier in this group is MPS 4, or Morquio syndrome. These patients develop profound skeletal dysplasia, specifically an underdeveloped cervical spine that creates a high risk of spinal cord compression. However, the disease spares the brain entirely, leaving them with 0 neurologic degeneration. Verifying whether the corneas are clouded and whether cognitive function is declining provides the exact coordinates needed to map an MPS patient's enzyme deficiency. Stepping outside the standard branches, we must examine 2 high-yield outliers that bypass typical sphingolipid and GAG pathways, requiring entirely different pattern recognition. The first is Pompe disease. Pompe is uniquely classified as glycogen storage disease type 2, making it the only LSD defined by the primary accumulation of glycogen in the lysosomes. This illustrated infant chest X-ray shows the infantile Pompe phenotype. Alongside profound muscle hypotonia, the glycogen packs the heart tissue, creating this pathognomic massively enlarged cardiac silhouette. The second outlier is Fabry disease. Returning to our genetic rules, Fabry is another of the rare X-linked exceptions. It is driven by a deficiency of alpha-galactosidase A, leading to a toxic buildup of globotriacylceramide, or GB3, in endothelial cells. Fabry presents early in childhood with very specific markers: clusters of dark red, non-blanching angiokeratomas concentrated between the umbilicus and knees, combined with acroparesthesias, debilitating episodic burning pain in the hands and feet. Because of its X-linked nature and specific substrate, Fabry exhibits a strict sex-based mortality divergence. Hemizygous males typically succumb to progressive renal failure as their kidneys pack with GB3. Females, governed by variable X chromosome inactivation, primarily die from cardiac hypertrophy and arrhythmias. Glycogen and GB3 accumulations do not cause rapid infant dementia. Instead, they create highly specialized, organ-specific mechanical failures that require targeted cardiovascular and renal monitoring. For decades, these metabolic errors were uniformly fatal. Today, we have enzyme replacement therapy, or ERT, which successfully clears visceral accumulations in diseases like Gaucher, Pompe, and Fabry. This visualizes systemic ERT. Infused recombinant enzymes smoothly diffuse into porous target tissues, reaching lysosomes to dissolve the dark, toxic substrate deposits. However, this therapy hits a fatal pharmacokinetic constraint when treating neurological LSDs, the blood-brain barrier. Intravenous enzymes are massive proteins, too large to squeeze through interlocked cerebral capillary walls. ERT perfectly cures the liver and spleen, but because drugs cannot reach the brain, patients with Gaucher type 3, Niemann-Pick type C, and MPS 1 suffer fatal central nervous system progression. Synthesizing the exact missing enzyme solves the biochemical equation, but it remains therapeutically useless for the mind if standard pharmacology cannot deliver it across the biological fortress of the brain. To treat the severe neurological forms of these diseases, modern medicine utilizes extreme physical interventions to force functional enzymes past the barrier. For Hurler and Krabbe disease, clinicians use hemopoietic stem cell transplants early in life. Donor macrophages act as a Trojan horse. They naturally migrate across the blood-brain barrier, taking up residence in the central nervous system to secrete functional enzymes directly into brain tissue. For CLN2 Batten disease, this schematic shows an intracerebral ventricular, or ICV, delivery system. A surgically implanted catheter port bypasses the vascular network entirely. It allows the physician to infuse the synthetic enzyme directly into the cerebrospinal fluid within the ventricles of the brain. Mastering the LSD diagnostic logic tree provides the definitive map for medical intervention. Identifying a cherry red spot or the specific geometry of an eye movement determines whether a patient receives standard infusion therapy or requires aggressive neurointervention to save their mind.